Please, if you have any questions at any point, feel free to unmute yourself and jump in. I have no problems if you have a question, if you want to interrupt. This is this is not the most exciting lecture in the world, so I would love for people to join in and participate, especially if you're very familiar with this topic and you have something that you'd like to add, because in no way am an expert on ASAM. My hope today is that we can talk about the ASAM level of care model. What is it? So by the end of this hour, you'll have familiarity with what it is and how to use it as a tool. To talk about how to integrate it in terms of best practice, assessment processes, and determining level of care, and why that is important for working with the population that we do. And then I just have a couple slides within the ASAM model to address, so what are these higher levels of care? What are their components, so that we can start to sort of differentiate between those the different levels. And to kind of embed that, I think it's important to address sort of what our past has been with treating substance abuse and why even buy into using a clinical decision-making tool like ASAM. Well, a piece of it is, I think, historically, we have not viewed substance use disorders or addictive disorders as chronic illnesses. We have tended to use either this complications-driven treatment paradigm or a diagnosis-driven treatment paradigm, where we essentially, people have problems, we put them into some kind of treatment, and then we don't do anything. It's a discrete episode until relapse occurs, then we put them back into the treatment cycle. So not seeing it as really a continuum of care, but sort of this a cycle of relapse, return to treatment, relapse, return to treatment. And the history within a lot of the substance abuse literature will show that it will, if someone is actively using, or if they're relapsing, we got to get them to rehab. We have to get them there. They do the 30 days, and they come back out treated. They go back to their life, and then we don't need to send them back until we see that relapse again. Well, that's not necessarily the most effective way to treat a chronic condition like addiction. So this is where we are now in terms of the field. What we're moving to is really understanding human beings are very complicated. And so we need to have a complicated paradigm to address that. So really seeing people as the whole person, looking at all the biopsychosocial components that comprise their life and making sure that treatment includes that complexity. So sort of thinking right from the get-go, a very involved assessment process, so I can see the multiple dimensions that are at play in this person's life. It's not just as simple as they're using, they need to stop using. We have to look at all the other variables that go into that cycle. Then we want to partner with them, not just fix the problem, but really partner with them on their perception of the problem, what their priorities are, because their priorities at that moment that they're entering into this system might not be sobriety. So thinking about how to build that alliance and look at the different priorities in their life and integrate that into treatment, along with their motivation, along with their willingness. So what are they actually willing to focus on and work on at that moment? So that's saying meeting them where they're at and walking the road with them. That is what actually informs the plan, and looking at the multiple levels within a continuum of care that they might need to take part of depending on where they are, with ongoing assessment of progress. And so seeing it as over the course of their recovery journey, this lifelong recovery journey, what are we monitoring in terms of functionality, social interpersonal outcomes, clinical functioning, their psychological well-being, and what are the sort of valid, reliable instruments that we're using for that ongoing measurement, which may or may not trigger either a return to an episode of care or not, and thinking that we want to keep people at the lowest level of care that is appropriate for them, rather than having them, if they have a slip, return all the way to a full 30-day inpatient or residential treatment, which might be appropriate, or it might not. If they could actually be handled at the outpatient level, or maybe even a peer support group, that would be preferred, because then that's a better match to the issues that are presenting. So thinking about it from sort of a more complicated perspective. So how do we begin to do this? How do we start to become really embedded in that perspective? Well, we really need to be utilizing effective screening and assessment, because that is sort of the first starting point, understanding what is going on with this person, screening everybody, and hopefully getting them tracked into some preventative care before they get to the residential or the intensive outpatient, before they get to the higher level of treatment. How can we offer treatment to people in the primary care setting? How can we offer it to them in the community? How can we get this thing called substance use destigmatized and looked at by the entire community as similar to diabetes or high blood pressure? How can we treat this at that lower level before it warrants the higher levels of care? And one way that we start to adopt that model is to think about the language that we're using, and start to understand what are episodes of care, and how can people engage in episodes of care over the course of their lifetime. So thinking about an episode of care as a defined set of services for a specific condition, and that this is typically short in duration. So how can I work with the person's presenting problems and needs right now for about 3 to 6 months or so, with ongoing monitoring, so that they can achieve some goals and some symptom remission with that focused episode of care, then reassess and say, do they need an additional episode of care in something else? Or do we take a break and then we reassess? And then we return to maybe a lower level episode of care. So sort of chunking treatment into these discrete, measurable, focused episodes. And that falls along this continuum model. So thinking that recovery is not a one-time shot, that this is really something that requires people transitioning across a series of services, and that they might hit wherever we're working, they might hit our level of care at any point, but then they're not done. That we have to understand that whole continuum and partner with each other to be able to move patients across those levels. So if I'm working at a medical detox unit and I'm seeing the people on the worst day of their life, that by the time I get them stable, I'm not letting them walk out my door without that next plan. What is the level of care that they need to transition to? Or if I'm working with someone in the community in a peer support group, how can I work with people when their symptoms start to exacerbate, or they start to decompensate for something? How do I now transition them and help them move to a higher level? So it's always thinking that we are links in a chain and we are connected in that way. So transitioning from one stage to another, and that could also roll in, because this is multidimensional, all the other treatment needs that people have. Case management needs, interpersonal, family, couples work, chronic pain treatment, chronic medical care management, Hep C treatment, all the things that come along with a human being. How do we include those providers and those specialty services in the continuum, in the patient's treatment plan? So one model that has been helpful to start to sort of think about this is just a sort of decision tree model. And I apologize for this hasn't been updated with, it still says DSM-4. But essentially starting with, when they enter the system, what do they actually want and why now? That can always be the first question that you ask. And then what are their immediate needs or their immediate risk? How do we assess for for those immediate needs to make sure that we are making an appropriate match. Because I'm going to show you a couple research studies at the end of this presentation that say that when we make a poor match, when we don't match the person to the right level of care, the likelihood that they're going to drop out of treatment or not respond well to treatment is very high. So it's really, really important day one that we make sure we are the right level of care for them. And then we conduct a multidimensional assessment to get all of that good information that's needed to make the appropriate diagnoses, to make sure that we are assessing for and putting together treatment to increase their functionality, so looking at loss of function, that we're using the right kinds of assessments to determine what the priorities are, the focus of treatment, what specific services are going to be needed to address each area of their life, and then what is the dose or the intensity of the service that's needed. So thinking about frequency, duration, and intensity of service as all rolled in. So individualized treatment, not a one-size-fits-all. That's kind of the take-home. And how do we do that? Well, that's really hard. So thinking about comprehensive assessment, it could obviously include many more things than just this, but this is sort of at a minimum, what we need to be collecting: medical, psych history, social history, legal history, review of psychiatric systems, demographic, employment, wrapping that all up into some kind of a case conceptualization with diagnosis and treatment. And definitely, if possible, using standardized assessments, any prior chart records or record review, and then talking to family, talking to collateral to get additional information. This is what would be required to collect at the offset. Then what do we do with all this information, right? There's a lot of information. How do we know what to do with it? Well, that's where ASAM comes into the picture. So ASAM is through the American Society of Addiction Medicine. It is a clinical tool. So there's more than one clinical tool out there, but this one is one that has been it's been well studied and widely disseminated. It is compliant with DSM-5. It's relatively user-friendly, so it's fairly easy to use. There's a computer program that you can purchase, the book that you can purchase to use in your setting. So it's kind of a user-friendly model that can be adopted by most providers, most clinicians, to help us be standardized in our clinical decision making. So that's kind of why I think it's been adopted by many states. And you can see that New Mexico is one that recommends that all substance use providers adopt the ASAM criteria. So we really should be unified in that approach. This is a diagram that sort of gives you the overall visual of what it takes. That comprehensive assessment information takes all of that information and tries to break it down into distinct dimensions and give you a vehicle for making a decision to match appropriate level of care along a continuum. So, like I said before, it starts with screening. So really, this matches up nicely with the SBIRT model, if anybody's familiar with SBIRT. So where we are screening for substance use issues in primary care settings, in community health clinics, and schools, kind of across the board. We're not waiting for people to come to us and tell us they have a substance use problem. We're going to them and we're screening everyone. And then screening, depending on how they respond, if it is positive, will trigger moving them into the next phase of assessment, where we would then want to diagnose a substance use disorder. Now that we have the diagnosis, because we've removed abuse and dependence, the diagnosis informs level of severity of that substance use disorder. So now we have, okay, yes, they meet criteria. What is the severity of the condition? But we also want to include their readiness for treatment. So those things combined lead us to these 6 dimensions, which look at their current intoxication withdrawal status, their biomedical status, their emotional behavioral status, treatment acceptance, how willing are they for treatment, where does treatment fit into their current life, what is their relapse potential or relapse risk right now, and then what is the recovery environment? So it's looking at this biopsychosocial perspective across these 6 dimensions, and then that information leads you to be able to make a clinical decision about what level of care is going to be most appropriate for this patient. So it can look like this, and it also matches up with, some of you might recognize these numbers as correlated with our billing and coding. So through Medicaid and our major payees that utilize these numbers. So moving from the high end, the number 4, medically managed inpatient services or acute detox services, to the inpatient level in the 3s, to residential, to IOP, and then to outpatient. And then the lower levels would be peer programming, early intervention planning. So now let's review the break down ASAM and review what all this means. So it utilizes 6 assessment dimensions, the ones that I read, looking at acute intoxication or withdrawal potential. What are their biomedical conditions and complications that we need to be considering? What's going on with them emotionally, behaviorally, cognitively, developmentally, and what complications do we need to consider? What is their level of change or their stage of change? What is their relapse risk or current use pattern if continued use is there? So that the use problem potential. And then what does the recovery environment look like? What are the environmental structures and supports that we're taking into consideration? So in the first dimension, what we're trying to assess is current risk level. Are they acutely intoxicated or potential for problematic withdrawal? Opiates, benzodiazepines, alcohol, all of these can have definitely alcohol and benzodiazepines, a lethal withdrawal component, but opiates, a very painful withdrawal component. So we want to be considering that right off the bat. So first thing, what is their current level of intoxication and or withdrawal potential? What is their risk level? You assess this by determining their use history, current signs of withdrawal, and there are several valid instruments to be able to measure current withdrawal, the COWS, the CEWA, and then what supports do they have in place to manage this? Because that's going to inform, can family get them to the emergency room? Do we have to call an ambulance to get them to the emergency room? If we are the emergency room, what other supports are in place to help them in their care with us and then to transition from us? Dimension 2, the biomedical conditions. Now we're looking at any current physical illnesses, any chronic health conditions, how are they managing and can they manage those conditions? And then what supports are they going to need to take care of themselves medically? What are the treatment recommendations that include the medical picture? So is Hep C a potential issue? Is there current cirrhotic activity that we need to be monitoring? Do they have issues with their kidney functioning? That sort of stuff we want to be considering, because that is also going to help to inform where this person needs to be in the continuum of care. We have a lot of patients that fall within the medically fragile column. Their substance use is well controlled, but because they're so medically fragile, they warrant a higher level of care to help them support and manage those pieces of their recovery, even though the use is well controlled. Dimension 3, the emotional, behavioral, cognitive conditions. This is where we want to be assessing for and considering what comorbid psychiatric illnesses are present. So is depression, anxiety, PTSD, OCD, schizophrenia, bipolar, what other issues that are going to require ongoing treatment or intervention that we need to be including in our treatment? Are these chronic? Is this a single episode, or is this an exacerbation? Are they part of the addictive disorder? What specific mental health treatment have they had in the past? What would they benefit from now? And what is their level of functioning as it pertains to this dimension? Are they able to take care of their ADLs, or is there significant loss of functioning? Because those are all things that are going to inform barriers to treating their substance use. If their depression is so severe that they can't get out of bed to come and see me, and I'm an outpatient therapist, I'm not going to be very effective. If their PTSD is so severe that they're avoiding coming to the clinic, I'm not going to be very effective. So I have to consider that in my my conceptualization of what level is recommended, which is why there are facilities like particularly at the VA, where they have dual residential programming for people with really severe PTSD so that they can go into a residential, a safe environment. They can do the exposure treatments that are needed to help them manage their PTSD more effectively, and then benefit from the substance use treatment. So that's why some of those programs have been developed and have been shown to be effective. Dimension 4, their readiness to change. So this is where we're adopting that stage of change model, and we're considering what is the person's sort of degree of readiness, what level of motivational enhancement might be needed to move them further along that stage of change continuum. Because those of you who are trained in MI, we know we can help people get ready, that it's not sufficient for us to say, well, they're just not ready and they'll come to treatment when they are. Actually, MI would say, no, we are responsible as the clinicians to help patients get ready. The questions that we ask, the methods that we use is part of how we nudge people in that direction. We don't give up on them and say, come back and see me when things have changed or when you've hit rock bottom. We can actually intervene way before then. So that's why I think it's really nice with ASAM that they include this readiness to change dimension, because it helps us to say, the person sitting in front of me, how willing and ready are they? Because that determination is going to inform how much MI or ME I might want to give to them, or I want to prioritize to move them further along so that they can really engage and benefit from the other treatment services. So everybody's familiar with this model, I'm sure, but just wanted to throw it in. So a lot of people with substance use disorders will enter treatment in the pre-contemplation stage. CYFD involvement, legal involvement, family involvement can all be sort of the pressures that trigger people to get help, but they don't necessarily see it as an issue, and they're not necessarily ready to work on it. So as treating providers, regardless of where we are in the continuum, having really solid training in MI and ME skills, and having that be like day one, some of the work that we do with them is only going to help us. So thinking about, no matter who they are, coming in pre-contemplation, some of that skill set can move them to contemplation, maybe even within that first meeting, right? And thinking about how to get them ready and moving towards the action stage where they can actually start to take steps to decrease their use or to move towards recovery. Okay, so these are some of the things that we might do, right? If they're coming in pre-contemplation, how do we raise some doubt? How do we get them to start to think about why they're coming? Like, well, what is, I'm just curious about why your family really wanted you to come in. Let's explore that a little bit. Let's talk about that. If they're coming in with contemplation, how do we start to tip that balance? How do we start to evoke what might be some really powerful reasons to change? What are the strengths that they have that they're not paying attention to, or that they're minimizing, that they could handle it, that they could do something, that they could tolerate whatever it is they're trying to run from? If they're in preparation, how do we help them determine, okay, what's the next course? What's the next step that we need to take? And then if they're in action, how do we just step back and let them start doing it for themselves? How do we let them sort of take the bus and drive? then if they're in maintenance, how do we recognize that we need to be making sure that they have solid relapse prevention skills, that people don't have to relapse. It is common, it's part of the condition, but it doesn't have to happen. And so let's talk about how to recognize the warning signs and get you prepared for when life gets stressful and when life gets messy, so you don't have to go back down that road. And then if relapse happens, how do you learn from it without thinking that you failed and you're starting from ground zero? How do you take all the skills and all that learning that you have, that you've gained with you, and pick back up and keep moving forward without being demoralized? So dimension 5, this is where we're looking at their relapse risk or their current use pattern. And on this dimension, it's nice because it also includes the mental health issues, looking at their full substance use history, sort of doing a functional analysis of the factors that either have led to relapse historically, the current relapse, if that's the phase that they're in when they're hitting you, or their current use pattern. And then identifying sort of what are the things that are driving it, that's coming before, the thoughts, feelings, the events, the triggers, what happens to them after they use, and then what are the skills that they have in place or the skills that they might need to be able to break out of that cycle. And then the final dimension, we're looking at the recovery environment. So looking at who are the supports in their family, the community supports, the therapeutic supports, the family supports, and then what complications to treatment do we want to be considering? Are they living with a substance user in the home? Are they actively being triggered? Are they in an unsafe environment? Is their housing stable? Do they have adequate childcare? Do they have adequate transportation? If it takes somebody 2 hours to get to me on the bus one way, the likelihood that they're going to come and see me as often as I'm recommending is pretty low. So I have to include those factors in my conceptualization to be able to make an informed recommendation of a level of care. Okay. Any questions at this juncture? Okay, jump in if you have a question. So each dimension that we just went through, all 6 dimensions, are rated on a severity level. So looking at low, moderate, or high within each dimension. So low severity within sort of level of functioning would mean that it's really minimal difficulty. There's really not a lot of symptoms in this particular dimension. Either if it's acute or if it's a chronic problem, it's pretty much stabilized, and they're functional across domains. So they don't really need immediate services, or they would benefit from a low intensity of services in this dimension. And then so my strategies, typically the recommendation is going to be outpatient or lower that's recommended for this. Moderate would be looking at there is now some difficulty and impairment. Some symptoms are coming on board. We're seeing a stress in the system, so some difficulty coping, difficulty functioning. They're going to need more moderate services, which might include psychoeducation, skills training, maybe some additional case management supports. And so for this, we might recommend a sort of wraparound outpatient program or an intensive outpatient program where they would still be in the community, they would still be living in their home, but they would come multiple times a day for large chunks of intervention. And then for a high level of severity, how this is impacting functioning, this is where we're seeing really gross functional impairment across dimensions, across domains. So lots of symptoms, really difficult, cannot cope, cannot tolerate, are unable to create sobriety windows for really any amount of time, are using at extremely high, risky levels, and or they just have zero supports, total chaotic environment. So they're going to need immediate urgent services, and this is where we're going to be thinking residential settings, inpatient or closely monitored settings, where they're going to have greater than daily intervention, so multiple per day intervention. So now let's talk about tools that you can use to now apply to these 6 dimensions. So this kind of brings in and gives you, I like at the top where it says the different levels 1 through 4, and shows you scores that correspond with both the audit and the DAST, which are 2 instruments that are directly correlated with ASAM level of care. So you can see that you know, the majority of people that are going to be screened on an instrument, primary care, wherever, are probably going to fall into that. Really don't need much. Might give them a little bit of education, but pretty much they stay at the bottom of the pyramid. Now, when we start getting into level 2, 3, and 4, that's where they start to hit treatment providers like us, where they're coming into a substance use specialty program of some kind. So the DAST, for those of you who are not familiar with it, there's a DAST 10 and a DAST 20. This is a valid instrument. It's called the Drug Abuse Screening Test. It comes in adult and adolescent versions, and it aligns with ASAM criteria. So you can give people the DAST either as a screener, or particularly it's meant for people that are coming into a substance abuse program, and their score will tell you what is the recommended ASAM level, which I think is really nice. So you can sort of say, with this one instrument, is the person sitting in front of me actually appropriate for the level of care that I'm providing, or do they need to go to a lower level, or do they need to go to a higher level? You can also administer the DAST multiple times, so over the course of an episode of care, you can administer it and you can see change over time. So someone that might be coming into an IOP or coming into a residential program with a very high score, severe score, they're absolutely appropriate for that level of care, but as they make improvement, we're going to want to see that score drop to the lower end. We're going to want it to be really in the 1 to 5 range to say, yes, you are appropriate to move to outpatient. The NM Assist is another tool. It's NIDA modified alcohol, smoking, and substance involvement screening test. This one's kind of cool because it's web-based, it's interactive. So you can do it on a tablet, you can have them do it on the computer, and it's set up so that the questions that they answer links them to either more questions or less questions. And then at the end, it gives them a referral that is consistent with the ASAM level. So you can do it with them or they can do it, and there is the link for you to get to that if you don't already use it. The Audit and the Audit C are other ones that correspond with ASAM. This is for alcohol specifically, and I'm sure most people are familiar with this. The first 3 questions are the Audit C, and all 10 questions is the full audit. So either one will give you an ASAM level. So those are just some. The SAMHSA website and the ASAM website include several other instruments that you can use. Some are public domain, some are not. The ones I showed you today are public domain, that you can use to include in utilizing the ASAM criteria. This I asked Hannah to make available to you guys as a handout, so I know it's a lot on one screen. So you have it as a handout that you can use, but this basically combines everything that we just talked about, those six dimensions, and then the levels of care, and gives you some discrete descriptors of what you would expect to see in that dimension. And it also tells you what is sort of the recommended frequency and intensity of services up at the top. So I think this is kind of a nice tool to have when you're first getting familiar or used to utilizing ASAM. So now let's talk about the higher levels of, do you have any questions that are coming up? I can't tell.
No, there's no questions. Yeah.
Okay.
So I was just about to send a chat to the group though to see if folks want all the handouts that you just spoke about, like the Audit C, the DAST.
Oh yeah.
Yeah,
we can provide those.
Yeah, I have copies of all of that. So
Perfect.
yeah, I'll email all the screening and all these tools after the presentation today to everyone.
Fantastic.
Cool.
Fantastic. Okay, so finish up some stuff here. So essentially, the nice thing about this tool is it gives us behaviorally sort of specific dimensions that we can look at to be able to say what is the most appropriate level of care for this patient at this point in time. And we always want to be referring them to the lowest appropriate level. because it is not necessarily going to be a good match or beneficial for someone to go to a higher level when they do not need that level of care. We want the people that really need it to be in those services. And if they don't really need it, then they should be engaging in outpatient or lower services. So I think that's why it's helpful to kind of focus on, okay, what would be the criteria for IOP or for residential, or what's called structured treatment residential. And so these slides kind of break down what are some of the things I would look for on each of the 6 dimensions. So dimension 1, intoxication, we're looking at that they don't need medically monitored, which is the highest level, right? That'd be 4. They are stable medically. If so, acute and intoxication, we can rule that out. If withdrawal is present, it's not life-threatening, right? Dimension 2, biomedical. So now we're saying there isn't medically fragile pieces that are going to require concurrent medical monitoring. Because if they need that, then they probably need to be in one of those higher level medical facilities until their medical condition stabilizes. Now, emotional behavioral stuff, this is where it would be appropriate to see people that have really difficulty with impulse control, maybe personality disorder that has been untreated, so really profound emotional dysregulation, low distress tolerance, their low skills with their interpersonal world. They have functional deficits that would really require like a 24-hour setting to teach them skills, or they could be really severe SMI, right? So their psychosis is not well treated, or their bipolar is not well treated, and they need a safe, structured environment in which to stabilize. Their readiness to change is also another one that we would see on the acute end, right? So a lot of difficulty or opposition to treatment, and they're engaging in very dangerous, high-risk behaviors. So they would, again, benefit from sort of that 24-hour ongoing motivational enhancement in a safe, structured environment. Relapses is something, either continued use or chronic severe relapse binge patterns is one that we would see that would require maybe a structured residential program. And then the recovery environment in which they're living is another dimension. So it's dangerous for them to be home, or they have a very unstable home situation. Again, they need that structured, safe environment in which to heal and recover. Oops, I need to click on the right thing. For IOP, there's going to be similar. So no, we're looking at very minimal risk of severe withdrawal. We're looking at stable medical issues. We're looking at less severe emotional behavioral issues, but still severe, right? So that mild severity. So they're stable enough to be in the community. They don't need 24/7 monitoring, but they need a higher frequency and intensity of intervention. So that sort of almost like a work structure. Come to the treatment, I do it every day, or I do it at least 3 times a week, and it's a fairly intense dosage. Readiness to change can be variable for people to engage in IOP. So they could go anywhere from pre-contemplation to pretty ambivalent, and still really benefit from the structure of an IOP. And so can relapse or continued use. And I know that some IOPs have a policy where if somebody relapses or if they're using, they're not allowed to be in the IOP. But ASAM would really recommend to say, actually, the people that are continuing to use and relapse, that they might be the ones that would benefit the most from that kind of a structure, because they're not able to maintain that on an outpatient basis, on purely outpatient basis. So maybe we want to consider, how do we work with these people that are continuing to use or are in a really severe relapse cycle? And again, the recovery environment isn't wholly unsafe or dangerous, but it's not necessarily supportive. So they need that structure and that support and sort of the wraparound service of an IOP. So that's sort of breaking that down. And then the last things I wanted to share, and then we can get to questions, is just sort of looking, okay, what is the research way out in terms of why should I buy into this ASAM model? Well, this is one study where they sort of looked at what is the impact of undermatching, and we know that the worst thing that can happen is people no showing or dropping out of treatment. We want people to be engaging in treatment because that's how they're going to get better. So when we don't match well, you can see we really have a worsening of outcomes. and it's across the board from all substances, and definitely that's the case with opiates and with stimulants. So we want to really make sure that we're matching well. What is the right level of care? And then the same thing looking at dropout and improvement. So what's happening when we match correctly, and then we step down services to that lowest level of recommended care. So the same thing, I work in outpatient, and I struggle a lot with our staff here because they're of the mindset we provide methadone. So people in methadone, they need to be in therapy for the rest of their lives. As long as they're in methadone, they need to be in therapy. And we're trying to change that culture to say, actually, once people reach maintenance, once they have shown that they can maintain their sobriety, that they're engaging in life in meaningful ways, that addiction is no longer on the table. They're taking this medication to maintain their recovery. We want to step down those requirements. We want to step down that level of service. We want to have them come to a once a month 30-minute aftercare group, right? We want them to start to become peers themselves and engage in more meaningful ways. We don't want to create a culture where people are stuck sort of even at the outpatient level for long periods of time, because that's a mismatch. So always thinking about what is the appropriate match for people, what is the lowest best choice for them to engage in, and how can we move people across that continuum and be flexible with moving people across that continuum, because they might need all levels of service at some point in their recovery, and that's okay. So being able to talk that language with them, to talk that language with other providers, and to be able to work collaboratively with each other, I think is one of the benefits of adopting a model like this. So that's all I got. Questions, comments?